And on the whole team, thank you to KMH for allowing us to do this presentation. It's our pleasure to share our work with you. So today we have packed agenda, hopefully very exciting. And we will have 2 speakers, and then we have 3 panelists. I'm going to start by introducing the speakers, and then we'll go ahead and start with the presentation. So our speakers today is Professor Dalton Wamalwa, who's a professor in the Department of Pediatrics and Child Health at the University of Nairobi. Professor Wamalwa has been conducting research in children living with HIV and even without HIV in Kenya over many years, and has contributed to guidelines in pediatric HIV testing, treatment, and monitoring for children living with HIV. And then we have Dr. Sarah Benke-Nugent, who is also a professor at the University of Washington, Department of Global Health. Sarah Benke has had long-term interest in child neurodevelopment and the impact of environmental exposure. She's been leading many studies in Kenya, focused on assessing and understanding neurodevelopment in children in Kenya for both those living with HIV and those who have been exposed to HIV. And then for our panelists, we have Dr. Grace John-Stewart, who's a professor in the Department of Pediatrics, Epidemiology, Global Health, and Medicine at the University of Washington. She's conducted maternal and child health research in Kenya for over 20 years. She lived in Kenya for several years earlier on in the ART era, pre-ART era, where when treatment was not available, and has worked closely with Professor Ruth Ndwati, Dorothy Boringacha, many of whom we know, who we know were really the pioneers of work that resulted in landmark changes to prevent mother-to-child transmission of HIV. She's continued dedicating to be a dedicated mentor to many Kenyan scientists and to many of us in this panel. And then as a panelist, we also have Dr. Brent Collette, who is a professor in the Department of Psychology at the University of Washington. He's a specialist in pediatric and adolescent psychology, and he's currently working on ongoing studies to assess neurodevelopment in Kenyan children. And then finally, we have Dr. Michelle Buteres, who's a postdoc at the University of Washington, Department of Global Health. And Michelle is very interested in supporting families that are affected by HIV, those who are living for families with children living with HIV or children who are exposed to HIV. So it's a wonderful panel. Welcome all of you, and I'll hand over to Professor Wamalwa. As Agnes has said, if you have any questions, please put them in the chat box, in the Q&A, and we'll address them at the end of the session. Thank you.
Thank you very much, Irene. I just to make sure that you can hear me and my slides are moving. I hope that's the case.
Yes, we can hear you. We can see your slides. Thank you.
Thank you very much. Thank you. It's a great honor to discuss this really exciting topic with us this evening and morning for those who are in Seattle. And we'll go through the spectrum of, really it's both neurodevelopmental and neurocognitive disorders, so there's slightly expanded definitions. Go a little on the pathogenesis, mechanisms, and then approach to management, touching on the role of antiretroviral therapy. So just looking back, many years back, as soon as HIV was identified, children started showing up with neurodevelopmental problems, serious ones. And over here is one of the scientists who played a big role in that, Dr. Oleske. And they would identify a few children, but they were very clearly having a pattern of losing developmental milestones. That's really a worry for parents and for caregivers. Children are meant to develop, so these babies would reach a point and just not gain milestones. And they would also have serious motor weakness, and no other cause could be identified than the fact that they were having this immunodeficiency syndrome. And then they would have microcephaly. So brain imaging was done in a few and showed shrunken brain atrophy. And at the time, the outcome was quite bad. And when autopsies were done, it showed corticothermia. So this came to be known by 1987 as HIV encephalopathy. And it was more common than thought, actually. So the series then found that up to 30 to 50% of the children with HIV would have encephalopathy. It would present typically with this triad of failure to gain or just losing developmental milestones, impaired brain growth, which would manifest as a small head, microcephaly, and on imaging atrophy, as well as motor deficits with weakness and paresis and spasticity. But then it was seen that there were two types. So one type would be very rapidly progressive, and I remember seeing some children like that in KNH in the early days, when you could literally have a CT scan done today, and when you do it 3 weeks later, you can see a huge difference in form of atrophy. And then there were those that would be more stable. We did a study with Grace and others here in 2009 OPH. And in that study in Kenyatta, actually quite a few children had microcephaly. When you look back, it's just about 18%, and it was associated with increased hazards for mortality. So this condition was included in AIDS defining criteria, as shown here. Then came antiretroviral therapy in the 90s, mid-90s, and you can see here, just looking at this chart on the right, it's self-explanatory. So around 1995, ART became available, and so more children coming onto ART. And then the incidence of HIV encephalopathy just dropped. It dropped dramatically, more than tenfold, and it stayed down. This is from a US cohort. This is probably the largest cohort that defined encephalopathy, almost 2,400 children enrolled in the 90s, followed up for quite some years. And again, in that cohort, about 5% had encephalopathy, median of 1.5 years, and really very, very severe detriment, because survival would just be 1.4 years. So the big thing here is that ART made a huge change. The incidence dropped of this serious brain injury in children. From the same cohort, we learned that there were certain drivers. You could identify things associated with encephalopathy. So just children with low CD4 baseline below 15% had a higher risk of getting encephalopathy. Infants were more likely to be affected, a threefold risk. But when we started ART, the incidence is reduced by more than 50%. And looking further, the type of antiretroviral therapy used was important. So if you had one that was CNS penetrating, so one that gets the drug into the CNS more effectively, then that reduced incidence of encephalopathy better than the one that doesn't. And even when a child had features of encephalopathy, when they were put on a CNS penetrating regimen, then they survived better. This is just to talk about the importance of the type of antiretroviral therapy used with regards to CNS penetration. And we'll talk about that a bit later. Now, many years later in South Africa, this from the SHARE study, a subset of it anyway. So these are infants who started treatment at a median of 9 weeks. We know about this cohort as a landmark study that helped us know that we should treat HIV early. About 15% of them had features of encephalopathy at a median of 31 months. And what I'd like to highlight here is that recovery can happen when children get onto ART for encephalopathy. So when you look at those features like upper motor neuron lesions, in that cohort, within 3 years, almost 4 years, 67% had full recovery. If you look at gross motor delay, again, huge number, 74 recovery, and language delay, which falls under the intellectual abilities, again, very high levels of recovery. Head growth, head circumference didn't recover so well. By 2 years, only 33% had recovered. They didn't show maybe much later, the recovery did continue. So the point here is that ART actually does change the natural history and tends towards recovery, as opposed to what was happening pre-ART when it would tend towards mortality. So looking at what really happens then in terms of pathogenesis? The thoughts are that one, there's direct replication of HIV in the CNS. So sort of this Trojan horse, HIV gets trafficked through to the CSF across the blood-brain barrier, and it gets in through these cells, which are activated in monocytes, macrophages, and so on. But and the evidence for that is that if you control CNS HIV using antiretroviral drugs, then you have better control and the clinical effect, so to speak. Now, the other part, though, that's more complicated is that it's not just having HIV there, but what it does in terms of inflammation with the cytokines and intrathecal inflammation, which may lead to increased demyelination. So this is regarding encephalopathy. So in summary, regarding encephalopathy, which is much rare now than before, it was higher in the pre-IRT period. It was worse in infants, especially when there was advanced HIV, and there was simply neurodevelopmental arrest and impaired brain growth. The brain just wouldn't grow. And we know that the incidence has been altered substantially by antiretroviral therapy. So we move on now to the second part, which is the neurocognitive disorders in children and adolescents. Now, this is an evolving field, but what do we know about this? We know that the prevalence is high by the current definitions. In people living with HIV can be as high as 70%, 30 to 70%. Generally, the global functioning remains normal, but certain domains get affected, and we shall talk about which ones. It can occur in the presence of long-term viral load suppression. So you can have virus suppressed, but still have these impairments. Now, the pathogenesis is not as clear. There are postulated mechanisms, and there's also a debate about definitions and classifications, especially in adults, much less so in children. So again, just the big picture here. So the main domains that are affected happen to be those that are really higher order, executive function, planning, working memory, processing speed, attention, concentration. These are really important things that we use every day, that children also use for learning, and they tend to be affected more than some of the other domains. We know that you can have mild forms, you can even have asymptomatic impairment. So everything is going on fine, but when you subject the child to neuropsychological testing, then you find that they are lagging. So this is the spectrum. Now, I've not come across a really well-defined classification in children, but we can borrow something from the classification that's used in adults, where there is a Frascati criterion, which is quite old and it's being challenged, but it shows the pattern sort of progression. So you can have symptomatic impairment. So in that case, when you have the cognitive tests, they are below one standard deviation from the matched normal values, but everything else is fine. Cognitive impairment does not interfere with daily living. Then you have the middle part, which is mild, and in that case, there's minimal interference, but the domains on the tests are also below, like up to one standard deviation. Then you have the more advanced. Remember, this is in adults, which is the more severe HIV-associated dementia, and in that case, definitely there is impairment of daily functioning. As I said, there isn't a standard one for children where we can borrow this, and in many studies, they sort of allude to a similar progression. So that tells us that the neuropsychological testing tends to be really important. Since some of them will be asymptomatic, some will be mild, we need to use these tests. And these tests are very varied, several. Here I'm showing the Baylor scales, which is for infants. We're using this in one of our studies. The domains would be as listed: cognition, communication, both receptive and expressive, fine and gross motor skills. And this test can take up to 50 minutes to test. Then we have the Malawi developmental tool, which is more tailored to our setting. Again, testing these domains, gross motor, fine, language, and social. We have for the older children, the Kaufman's battery, which tests global abilities. And this can take as long as 75 minutes. And as you can see, the material which is used will assess short-term memory, visual spatial processing learning, and so on. And NIH has also the NIH toolbox for older children from 7 years. Again, can be used for language, expressive, both expressive and receptive language, memory, processing speed. And then there's this interesting one that we're using in one of the studies, executive function, EF touch, which is tablets-based. So several tests that can be used. I'll just give an example of this executive function test, EF touch. So for instance, what you're seeing on your screen on the right would say, you can see a blue dot, a yellow dot, and a red dot. So this is what the child will see on the screen, and the command would be to touch the red dots. And so they're listening to the command, following instructions, they're remembering what you've said, and they touch that. There's another one here, which has got two living organisms. So one is a bird, one is a cat. So the command here would be touch the bird. And so obviously it assumes that the child knows what a bird is. So they remember you said touch the bird in real time, and they click and touch the bird. Now another one here, again, still on this example. So what would happen here, it's tablets based, remember. So in this game, these are the instructions. I want you to press the green button as fast as you can every time you see an animal, but not when it is a pig. So in that case, the next step is, this is the animal, and the instruction here is a cat. Should you touch the green button? If the child remembers what they were told, then they will not touch. Yes, they will touch because it is not a pig. So here it is. They have touched it, and they said, yes, it's not a pig. So they can remember you gave instructions. So the next one, here is a pig. Should you touch the green button? And the correct answer there would be no, because it is a pig. So it's the child, you're testing whether the child can be inhibited, or do they just keep clicking throughout? They're supposed to listen, understand that command, remember that they shouldn't press it when it's a pig. And when you use the first one, there wasn't a pig, and they press. So this is an example of what would happen. Now, moving on to more of the findings, what the studies have shown us about these neurocognitive impairments. So Nicole Phillips did a meta-analysis. Many studies, and 7 of the 22 are from Africa, Sub-Saharan Africa. They're mainly comparing children with HIV to those without HIV. And like I mentioned earlier, the biggest problems where there's a biggest difference was seen in these areas: working memory. Working memory means that somebody has the ability to remember, to keep information in the mind that you need to complete a task. Processing speed. When you get information, you need to process it and respond. That was also impaired. And executive function, which is sort of used to control and coordinate other abilities. So when you think about it, these are fairly serious domains which affect academic achievement, they affect relationship, they will ultimately affect employment and income and health-seeking behavior. So these domains are critical, and they tend to be affected. Now, just looking at specific ages. So in the young children, this first column talks about the study again from South Africa, the SHARE study. So what they found here, these were 4 groups of children. Some studied antiretroviral late about 40 weeks, just 9 months or so. Another group started early by 7 weeks. Then there was a group that was exposed to HIV but did not have HIV, and then another group that did not have any HIV exposure, and they were evaluated at 11 months. Now, obviously, these are small numbers, but the main outcome here is that those children who started antiretroviral therapy early did better than those who started late. In fact, they did as well, almost as well as those without HIV, except on the motor scale. So they did well on language at 11 months. Remember, this is very early on. So they did that. Now, what's interesting is that later, when some of the same children were assessed, the age of 7 to 9 years, remember, these are children who had studied ART early and had performed almost as well as those without HIV. But by 7 to 9 years, it wasn't the case. Those both starting early and late were performing worse on key things such as auditory working memory and executive function. So what this tells us, though the study is really sample size is small, but is that there's some level of risk that remains even when they started early. But again, remember they started ART at 7 weeks. And we know that these are babies who may have got HIV either before birth or during birth, early breastfeeding. So it's early, but again, not necessarily as early. Now, another group again from a different cohort. These are older children, different countries in Southern Africa, and the P1060 cohort. This one started ART much later, but less than 3 years. And again, compared to children who are exposed to HIV, but without HIV, that's HIV exposed, uninfected, but also a control of those without exposure to HIV. So that's HIV unexposed and infected, and they're assessed with different levels. So what you see on this chart is a very clear pattern where the children with HIV perform worse, both at baseline, at 48 weeks, and at 96 weeks. And they're performing worse on different aspects, sequential processing, simultaneous processing, learning, planning. These are executive function things, and language. So you can see that those who are exposed are sort of in the middle, and those without HIV are performing the best. So again, just saying that this can be quite consistent, even when children we think have started antiretroviral therapy relatively early. You might think 3 years is early. That's not the case here. Now, what about the older children, the adolescents? This is a study out of New York. Older children got into care at 9 to 16 years. Fairly large group, about 200 and 100. So they were followed up for 6 years and assessed. And again, what happens here, the two things. So one is that those who had history of AIDS and higher viral loads performed worse on executive function. But as time went, again, there was this poor trajectory among these children in processing speed. Then the final one here from Zambia, very close to us, large group again, children between 8 and 17 years who started ART, followed up for 2 years, performed worse again on cognitive tests, and especially processing speeds. And it was found in that study, those who did the worst are those who had, advanced HIV, which you can measure by poor growth, low CD4s, and the WHO stage, which is advanced. And as time went on, there wasn't much change. So there wasn't much recovery in these worst scores. Now, Sarah Benke, who's going to talk after this, will talk about some of the studies we've done in Kenyatta. Moving on to thinking about the causes, one thing is increasingly clear that this condition would be multifactorial. So it's hard to point and say this is only because of HIV. There are many other factors that these children are exposed to. We know that socioeconomic status matters, access to education. We know that nutrition matters. So a child who's malnourished will do worse. And then we know about the toxicity of certain antiretroviral drugs, the setup that produces inflammation, and all these factors affect the cognitive function of a child or an adolescent. So that recognition is definitely growing. However, we know that this, what we could refer to as HIV brain pathology, we could call it HIV-associated brain injury. And we're also, at this point, noticing then why is antiretroviral therapy not as effective? There are several reasons for this. The first thing is that the CNS is known to be really a reservoir. It harbors viral replication. So just because we have suppression of HIV in the plasma, it doesn't mean that there's suppression in the CNS. So you can have CSF escape, where we have CSF viremia in the presence of suppressed plasma RNA. That's a classic escape. Or if you measure these CSF RNA levels and they are much higher than the plasma, then it means there's ongoing replication in CSF. So that's one reason why that the ART would not work in that case. Toxicity by antiretroviral drugs, some of them, we know about efavirenz and some of the integrase strand transfer inhibitors, but also other antiretroviral drugs shown in vivo to cause damage to neurons, such as ritonavir and tazanavir. And then the final one, which is really important, is that these disorders may not simply be a consequence of direct effects, which can be affected by ART, but due to sustained immune activation. And as you know, immune activation then would cause excitation or neuroinflammation, and that can continue just because of other proteins, and it's not addressed directly by antiretroviral therapy. Turning to brain imaging, which is increasingly important. We know we can't look into the brain with our eyes, but we can look into the brain with the images, with the diagnostic imaging. So whether it's MRI or CT, the most common abnormalities that have been shown as these children are reviewed, and there's a good review by Ohore in 2014, ventricular enlargement, cortical and subcortical atrophy, lower gray matter and sometimes gray matter, even white matter atrophy, cortical thinning, abnormalities in the frontal white and gray matter, and basal ganglia abnormalities. These have been shown. However, they don't always correlate directly with the clinical picture. It's more complex. And then we have magnetic resonance spectroscopy, which is a technique where the radiologists would use specific software, and they would correlate it with the neurometabolite concentration. So for instance, N-acetyl aspartate, we know that it's a proxy for neuronal density and integrity. And so if there is a loss of neuronal integrity, then N-acetyl aspartate will decrease. Choline, on the other hand, if there is increased turnover and gliosis, choline would go up, and creatine, which marks cellular energy, if it's again increased turnover because the energy is required, then it will go up. So there's a study, it's a small study here, but in adults living with HIV, and compared with controls, and it actually did show that that was the case. You could almost correlate these changes in neurometabolite concentration with HIV. So with damage. So this is an area again which may see increased study. Then yeah, fine. So we go now, as we come to the end of the talk, towards management of these conditions. So first of all, antiretroviral therapy, especially early antiretroviral therapy, is important. That should not be taken lightly. It's very important. So all the patients need to be on effective antiretroviral therapy. It's the one that has been shown to have the biggest impact anyway. Now, there are also other interventions that have been found to work in neurocognitive disorders which are not related to HIV. So caregiver training, Mike Boyven has shown that, and then to some extent mixed picture, but certain vitamins, certainly supplementation. Then you have the nurturing care framework, and finally exploration and adjuvant therapies. Now, I'll talk a little again about CNS penetrating effectiveness. I touched on it when I talked about encephalopathy. So we know the different antiretroviral uh, classes. We know the NRTIs, we know the NNRTIs, we know the PIs, fusion inhibitors, we know the INSTI. So what happens here is that if the penetration is high, the score is a 4. If it's low, the score is a 1. And this has been worked out using characteristics of the drugs. But essentially, high score means that more drug will be available in the CNS, and a low score means that less drug will be available. And the more the drug, then the more ability to reduce CSF viremia. So you see, AZT, zidovudine, very good here. Very high score in this group, followed by bacavir and much lower scores with tenofovir. Then you have nevirapine, which are not using much now, followed by efavirenz. And PI is not really great, but lopinavir and darunavir do better than atazanavir. And then, fortunately, now I know many children are on dolutegravir, and it actually does well, even better than tegravir. So if you have a combination of 3 drugs, then you just add that score and you get the total. And if the total is less than 8, that's really low. If it's above 9 and above, that's good. Most of the children we have would be on regimens that contain dolutegravir. Now, previously were on lopinavir, and I'd say they would be in the high. Okay, so a few studies have also looked at, now again in adults, because we don't have much in children, but what it seems clear is that the earlier the ART, the better. If you can get ART in as early as possible. We know we've talked about that for cure and for the reservoir. So there's a small study here that studied ART within 17 days of infection in adults and followed up these adults. And they found that you get a lower RNA level in the CSF. You suppress it in a very large number of people, almost 96% by 96 weeks. And also you get less immune activation. If you measure that again, the level of immune activation goes low. It's almost as if they're HIV negative. The interpretation of this is that early ART may reduce the size of the HIV CNS latent reservoir. More work obviously is required to do this. This is a small study. The other thing is intensification. So using that CNS penetrating effectiveness, making sure that you have drugs that have high effectiveness. And I've talked about the dolutegravir. The regimens that we have are reasonable. One small study, again, added maraviroc and showed improved neurocognitive function. I wouldn't say that this is necessarily translated to policy, but it's just proving the concept further. And most important is to have regimens that suppress plasma RNA, because it still is an important predictor of CSF RNA. You can't start talking about controlling CSF RNA when you still have plasma RNA elevated. So regimens should be simplified in a way that they also can suppress plasma RNA. I talked about Boivin and his group. So what they did in Uganda is to train caregivers using this intervention called Miss Canelo Cyrus is in the audience, and Cyrus did this also here in Kenya. But basically, they would have psychologists or social workers go to their home, and using resources that are at home, they would train the caregiver on how to interact with the child. And Brent is on the panel, and I'm sure he'll talk a little about that, because it's a really exciting area. But they help the caregiver to get the child's attention, learning, and use that session to apply to other situations. Remember, they're using materials that are in the home. So they're not asking the parents to buy new toys. They just use what's there, but they give time. And this showed improvement in receptive language and in visual spatial memory. This was not in the setting of HIV. So the nurturing framework is out there. It's but the WHO, UNICEF sort of strategy, and just for us to remember, helps us to remember that children need nutrition. They need to be protected from other health problems. There's no need, even if we control HIV and then we have meningitis or we have immunizable diseases, child didn't get immunized, again, we still lose. So protection, Michelle will talk a little about that in terms of just the social environment, the father being there and so on. Then learning, parenting. You can see this little girl is very happy. And finally, I won't spend too much time on this, just to show that many things have been tried. Adjuvant neuroprotective therapies, none of them so far has shown impact on improving outcomes. Acetylcholinesterase inhibitors have been tried in RCTs. Lithium has been tried, the alanine, minocycline. So basically, it makes sense that if you reduce inflammation, then there'll be less benefits. There'll be less injury to the neurocognitive domain, but in trials that has not really happened. So finally, as I end, I'll just point out this really just for sort of to think about this a drive to reclassify these domains. And there's a good review in Nature that last year, which is available here. And why reclassify? Two things have been proposed. That one, we should classify these conditions in a way that we distinguish HIV-associated brain injury from other cognitive impairments, from other causes. It's easier said than done, but that's what's proposed. And it's, as I said, it's a discussion. So what would happen is that you'd classify, this is HIV-associated, and then this is other. And other could mean, for instance, a child who has cerebral palsy, who had meningitis, who had toxicity, who had uncontrolled epilepsy, and you wouldn't sort of mix them. As I said, easier said than done. And then that one who has HIV associated, then you'd look and see, is the plasma RNA suppressed? And if it's suppressed, then you say that that's probably things that happened before ART. But if it's not suppressed, then we know that it might still be active. So that's one part of the proposal, which is, again, as I said, altruistic, but good to know that it's there. And secondly, which I think is more important, this revision would recommend that clinical assessment should be made before you label an individual as having cognitive impairment. So in that case, three things. One, take history and see how the child is doing cognitively. And then two, have the tests, the neuropsychological tests, and finally have investigations. So those are the things that have been proposed. And I think this is my last slide. So in summary, we have, like I've discussed, neurocognitive compromise is common. It's more significant in those with advanced disease. Early ART may be promising. If we can get early ART in and get drugs that get into the CNS, but without toxicity, with less toxicity, that would be good. But we still have work to do. We have to define biomarkers, CNS injury, and if we could get agents that can reverse the effect of the reservoir, the latent reservoir, then that would be fabulous. And finally, this is some ongoing. Thank you very much. That's my final slides. Thank you. And back to you, Irene.
Thank you very much, Professor Omalo, for that presentation. As a reminder, please put your questions in the chat box. We'll answer them at the end of the presentations. Go ahead, Sarah Bentley. Great. Looks good, Sarah. Sarah, you're on mute.
Okay.
Yeah.
Sorry. I had asked if you want me to start. Will you take questions now, or you want me to go ahead and start?
I think go ahead and start, and then we'll take questions at the end.
Okay. All right. Sorry for that delay. Thank you so much for the opportunity to speak with you today. I'm just delighted to share a little bit about the work that we've done for the past several years to try to understand this question of how do we optimize healthy neurodevelopment and perinatal HIV, and really grateful to Prof for taking us through for covering just a lot of ground in a really effective way. And what I will do is just share on the studies that we've done here in Kenya. So I will take you through some studies that we've done to understand the short and the long-term neurodevelopmental outcomes in very specifically early treated children in Kenya. And I will tell you a little bit about the studies that we did to try to understand, these mechanisms of impairment. How does that exactly work in the body? And then I'll touch on the importance of early treatment, and I'll end with just some thoughts on the gaps and ideas that I have for how best we can begin to go to the next level to really try and support these children who are at risk for poor functioning in their everyday lives. So this slide is meant to highlight a point that I feel like is very important to consider when we're talking about the long-term outcomes of these children living with HIV. UNAIDS now estimates there are 1.5 million children right now in the world. And this chart takes us through the trajectory of ART coverage over a little over the past 10 years in two groups. In the yellow, we see pregnant women living with HIV, and in the green, we see children under 15 who are living with HIV. And the point is that, yes, there's been progress in ART coverage for these children over the past many years, but as of 2021, coverage was just over 52%. And in 2022, a little bit higher, but really not much. And so we still have a situation where over 40% of these children do not have access to treatment. So Prof highlighted just how common it is for children living with HIV to have neurocognitive impairments. And, the wealth of data that we have on this topic really comes from a very heterogeneous set of studies involving cohorts over time that may have had access to now obsolete guidelines. And about over 10 years ago, we were really interested in understanding, what would the prospects be for children with HIV who had access to very early treatment in infancy. And as Prof mentioned, we began to do this work in 2007. And the children that we focused on, we leveraged a cohort of children who were enrolled as part of a randomized trial. They started ART at a median of 5 months of age, and many of them had symptomatic HIV. Many of them had very low CD4 percentages, and many of them were underweight and had stunting. And we did something very, very practical. We compared their developmental milestone attainment to a comparison group of children who were HIV unexposed and uninfected. And what we found was that these children, or these infants, as they were followed routinely every month for their developmental milestone attainment, we found that they had later age at sitting, later age at walking, later age at monosyllabic speech. And the chart on the right shows you what that looked like for just one of the milestones that I mentioned. So for speech, for example, I'm showing you a chart that plots when each group of infants attained monosyllabic speech. And the curve on the left in the darkest color corresponds to the infants without HIV, without HIV exposure. And the two lines on the right show trajectories for two groups of infants, one with HIV, but who had achieved viral suppression within the first 6 months on treatment, and one with HIV who had not. And you can see that both of these groups of infants with HIV, whether they had achieved virologic suppression or not, still attained speech later than the HIV unexposed, uninfected infants. Now, many of these infants were retained in follow-up, and when they were 7 years old, we were able to do a detailed battery of neurocognitive assessments, and we compared them to another group, again, to children who were around the same age and not exposed to HIV, not infected. And we used the assessment that Prof mentioned, the Kaufman assessment battery for children, to do this. We also used other tests, one of which was the test of variables of attention. We used the Bruininks-Osretzi test of motor proficiency. And then we used a assessment called the Behavior Rating Inventory of Executive Function. Now, most of these assessments are administered by a clinician, as you can see here, who administers what the child would perceive as, a fun activity, a game-like task. And the point of these activities is to try to understand, how they function in a variety of aspects of their cognition. That is basically the process of doing what Prof mentioned would be a neuropsychological assessment. One of these assessments, the Behavior Rating Inventory of Executive Function, that one worked a little bit differently. So in this assessment, we asked caregivers about their child's functioning in their everyday lives. And we asked them questions that were relevant to both their ability to plan and monitor their ability to complete tasks, as well as their ability to regulate their behavior. So these tests that we did covered a lot of ground. Some of them addressed the child's motor skills, their ability to do fine motor activities, and their ability to balance and their overall coordination. We also looked at memory and learning. So one task, for example, involved reading a series of numbers to a child and asking them to retrieve those numbers in a very short period of time. Another test that we did was similar to the one that Prof alluded to. It involved a computer screen, and the children weren't asked to look at images of cats or pigs, but they were asked to look at a very boring black box on a computer screen. And they were asked to press a button when they saw that black box appear in a certain part of the screen. And so we would call that our target stimulus. And so we tracked their ability to maintain their attention in this very boring task. And we also tracked their ability to respond when they were meant to press that button. So that was our way of measuring their processing speed. So when we compared this group of early treated children to children who were unexposed, uninfected, despite that early treatment, we found that these children had significantly lower scores for global cognition, short-term memory, processing speed, and behavioral regulation. And we were really struck by these results, partly because we were hopeful that these children would have better outcomes, given that they had been treated very early in life. And we were also struck by the fact that the deficits that we noted in this small group of children were very similar to deficits that had been noted by the other studies that Prof described so clearly. So we wanted to understand whether there were biomarkers for the deficits that we observed in these children. And we looked specifically at markers of some of the cells that Prof alluded to. So he talked a little bit about the types of cells that move into the brain in a person with HIV. And some of the cells that people think are really important are monocytes and macrophages. So we were very interested in understanding whether or not these children that we were following in Kenya had higher levels or any differences in their monocyte markers. Of course, we couldn't look in the brain, but we could look in their bloodstream. And this was, also based on a small number of clinical studies that found that these types of cells were also associated with HIV encephalopathy and dementia and cognitive deficits in adults, and then HIV encephalopathy in infants. And so we didn't look at the cells themselves, but we looked at a soluble marker for the cells, and that soluble marker is soluble CD163. And we found that despite the fact that we did have a relatively small cohort, during the earliest period of time when these infants had started ART, those that had higher levels of soluble CD163 during infancy both had later age at their developmental milestones, including monosyllabic speech. And then when they were older, these children who had had this legacy of higher levels of soluble CD163 also had trends for global cognitive ability, for lower functioning in their short-term memory, and then also lower functioning on another composite that was specifically focused on nonverbal test performance. So last, I'll just share our final question related to this cohort of early treated children in whom we had seen these deficits in cognition, in memory, processing speed, and behavioral regulation. We wanted to understand, okay, so they have these deficits. How does this really compare to children who started ART perhaps early in life, but not quite as early as during infancy? So we had an opportunity to do this in a very nice way because we had access to recruitment of children who were similar to these early treated infants in that they were identified at Kenyatta National Hospital. And so we anticipated that this group would have a lot of demographic similarities to our early treated group. And we wanted to understand how they compared. And what we found was that these children who had started ART just a little bit later had lower scores in global cognition, nonverbal test performance, memory, visual spatial processing, learning, executive functioning, and also motor scores compared to early treated children. So I'll just summarize what I've shared today by highlighting some implications of this, which are that, treatment in infancy, as Prof highlighted, is partially protective, and we did identify deficits in this group that align with prior studies, which was reassuring. But I think the main take-home message is just, this cost of the lag in pediatric treatment that I highlighted at the beginning of my talk. And the other important note would be that, in these infants who had been treated early on in their life in Kenya, their treatment at a median of 5 months is still, quite a bit later than what would be mandated by early infant diagnosis protocols. And, UNAIDS estimates that, still, unfortunately, a small, just a small proportion of children living with HIV have access to that kind of timely treatment. So we did see that there were some biomarkers that in these early treated children that seemed to be important and mapped to the cognitive deficits. And I think that that was reassuring that this was similar to what has been shown in adults. And I feel like these are important because it does offer some clues as far as therapeutics. So some of the gaps that I'm hoping that we can continue to try to address is, one, I talked about that we assessed children using the Behavior Rating Inventory of Executive Functioning. This is a US-based test, and it's meant to assess, everyday activities. And, you really wonder, how relevant it is. And I think one of the things that I'm hoping can be done moving forward is to really develop and gain consensus around methods for assessment of everyday functioning in children with HIV that's actually appropriate for the context. And we also need more scalable tools for neuropsychological assessment. We worked really hard with a small group of assessors and did a lot of skills training and QC ongoing. It's difficult for programs to take up methods for neuropsychological assessment. But if we had less skill-intensive ones, perhaps that could be done more widely. And Prof highlighted the importance of the nurturing care framework. One important gap that I would highlight is just how do we implement nurturing care more broadly for children living with HIV, given its importance and potential benefit for children during their early years. And then finally, we really need to understand just what it would be the best tools to use to support caregivers of school-age children and adolescents who might be at risk for poor functioning in their everyday lives. So with that, I will end and take questions, and I will put up an acknowledgement slide just to extend a very warm thank you to all of the individuals who worked so hard on these studies, and I'm quite grateful for the opportunity to share the work with you today.
Thank you very much, Sarah, for another really excellent presentation. Before we move on to the questions, I think let's open the panel. Let's just open it up to the panel for some comments. So we'll start with Dr. John Stewart, and then Dr. Colette, and then Dr. Volteris. We can see half half your slide.
Okay.
Yeah, maybe just put slideshow and if you, yeah, okay, sorry. Okay. That's better.
Yeah,
it's perfect.
That was such a great overview, and I just have a few concepts that I thought might be complementary. Really enjoyed what has already been given in this presentation by Prof. Amala and Dr. Benke-Nugent. And I was just at the CROI meeting where some of the neuropathogenesis studies and advances in neuropathogenesis were presented 2 weeks ago. And I thought, as we're thinking about research or where we can go further, it was just interesting to see some of the ideas that people are exploring in adults and in children. And so there's a lot of new work really trying to understand what is happening in the brain of individuals, both with and without viral suppression, and trying to understand where activation occurs, which cells are affected, and which regions are affected. And so there was one very nice presentation looking with PET scanning and with specific markers to look for microglial activation, and then trying to understand how much and which locations were associated with cognitive control and declarative memory regions. And in this study of adults, they were able to demonstrate that individuals, even though they're fully suppressed, might have some increased microglial activation, and those are associated with some cognitive control issues. Another really interesting thing to think about is trying to understand how vascular etiologies might contribute to neuropathogenesis. And this may be more an issue in adults than children, but as we're watching children grow up from birth to adolescence to early adulthood, it's something to keep in mind. And there was a very large study in over almost 14,000 adults looking at whether depression was associated with stroke and finding an association there. And again, mechanisms aren't really clearly understood yet, but it was an intriguing presentation. Related to that, some work looking at PET scanning of carotids. So not just looking at the structure of the carotid, but looking at inflammation in the carotids. In adults, they found increased associations with decreased cognition. And finally, I think, as was so nicely highlighted by Prof in the beginning, even with very good suppression, it's possible to have neurocognitive impairment. And I think people are very interested in this. And so CSF studies to understand what level of CSF virus or inflammation is responsible are important. And one of the points that was made is there's, the blood compartment, there's the CSF compartment, and there's the brain, and they're three separate things. And the CSF is kind of in between, but it's an imperfect proxy measure that I think people are interested in studying further. A nice study looking in children was this one that made the point that when you're having a delay or a deficit in one domain, sometimes it's related to a deficit or a delay in another domain. And as you grow up, you start kind of connecting domains together. And what this study found, it was from Thailand, and you can see on the top, early adolescence, there's less connection of domains in the early adolescence and more connection as they get to middle adolescence. But what you can see is that the connection density is lower in children with HIV and even in children with HIV exposure than children without. So this team was trying to make a point that there could have been something that happened early in life that then has a trajectory that makes it harder to connect domains later in life. I think Dr. Benke-Nugent alluded to the fact that, in a busy clinic, we're really trying to understand, is there some simple test, not one that requires a long period of time and detailed scanning? What would that simple test be? And I think there's a lot of research in this area. This paper just came out this year, trying to look at simple tests of central auditory function. And this is not about hearing per se. This is about how you take information from what you hear and then act on it. And in this study, this was done in Tanzania, they found that some of these simple central auditory tests were very predictive of future cognitive outcomes. So I think this space may be one that's interesting to pursue in the future. So finally, from my perspective on the panel, some of the big picture concepts that that people are thinking about in designing research are to remember that when we're talking about children and adolescents, there's quite distinct populations. And so when you're talking about a 15-year-old who comes into clinic, that 15-year-old might have vertically acquired infection from birth or horizontally acquired infection recently. They're not the same thing. So understanding that when we're designing our cohorts or evaluating neurocognition will be important. Prof already alluded to this multifactorial set of influences like nutrition and social milieu and violence and other things that might affect neuropathogenesis. And I think it's going to continue to be important to incorporate research in understanding how to think about that. We don't know what functional outcomes are the most relevant. And so at the end of the day, everybody would like for the children that we're working with to have the best potential for their long-term performance and occupations. And what is it that we can measure and optimize while they're children and adolescents that will ensure that they have the best outcomes? And I think that's an area that we'd like to know more about, and that will help us in terms of screening approaches. Research, you can see from the things I shared from Croy, is really trying to understand mechanisms and localization, but there's some need for implementation science research for simpler screening. And I think trying to understand better these links between cognitive and mental health. And finally, as Prof had alluded to, we really don't know the best intervention. So even as we screen, trying to figure out what would be the best types of intervention to help optimize care is something that we're thinking about as designing research to help children. And I'll end there and pass off to our next panelist.
Dr. Cook?
Yeah, thanks, Irene. And thank you for these talks. These are just amazing. And I always learn a lot just listening to all of you. I don't have slides prepared, I'm afraid, but I do have thoughts just based on the talks by Dr. Wamalwa and Benki. Dr. Wamalwa correctly pointed out that executive function is both vulnerable to insults like prenatal HIV exposure and many, many others, and associated with a wide range of important outcomes. So health outcomes, economic outcomes, social outcomes are all closely related to executive function, which is both good news and bad news, of course. So the bad news part of that is that if you've got a deficit in executive function, that potentially portends bad outcomes in a range of other areas. One of the bits of good news is that this is a very promising target for intervention, and executive functions develop relatively late in childhood and even through adolescence, and so it's a malleable target for intervention for a relatively long period of time. And so the things that we are thinking about a lot are just how to best intervene and when and who ought to be involved and all of those sorts of things. The things that I'm most interested in are interventions for young kids. So 0 to 5 is kind of my particular area of interest. And there's a lot of good evidence that suggests that caregiver-based interventions, like the intervention that Michael Boyven and others tested and others, might help both directly with outcomes like language and parent-child relationships and things like that, but also later outcomes with executive function. And so for us, that seems like an especially promising direction, because we know that overall the benefits of any intervention are greatest when it's provided early. And there's lots of good reason to think that things might be more malleable for young kids. The other thing that I'm thinking about is that it's probably not going to be a one-shot intervention. Even if we are lucky enough to find an intervention that works well and that people actually use and gets implemented, it's somewhat unlikely that we're going to do one thing at a very early age and it's going to inoculate kids for the duration, and they're not ever going to struggle if they're vulnerable. So one of the things that we're thinking about is just how interventions might be timed, and how there might be different layers of intervention based on child age, so that we might be bolstering these kinds of skills through life, through childhood and adolescence at least. And I guess the last thing that was coming to mind as I was hearing the different talks and thinking about what the potentials for intervention are, there has been some thought that these things ought to be directly targeted. So Dr. Wamalwa showed those tasks that we use with the EF Touch. And in the US, at least, there has been some thought that maybe we could directly target some of those things. So we could essentially teach people how to be really good at those tasks, and that might generalize in important ways. And to me, that overall seems unlikely. I think we could certainly intervene and have kids be quicker at touching the button, or be careful not to touch the button when they see a pig, but they do touch the button when they see a cat. But I'm skeptical about that kind of thing generalizing well. And so one of the things that we think might be more promising would be targeting other skills that are related to executive function, but also might have real world implications. So as an example, language is very closely related to executive function. And so there's reasonable thought that a really good language intervention might also help with some of these executive functions later in life, or that a motor skills intervention that targets some of those delays and milestones, like Dr. Benke-Nugent pointed out, that those things might also be helpful for executive function. And to me, that seems like it has a little bit more promise in terms of meaningful effects and longer lasting effects. Those are my primary thoughts. It's a really exciting area. I think there's just a ton of potential here, and the groundwork, it seems like, has been very well laid out, and the opportunity for intervention is really great.
Thank you, Dr. Collette.
Yeah.
Dr. Buteri?
Hi, everyone. Thank you so much for really outstanding talks. And I'm really honored to be here today. So I also am not sharing slides today. Doctors Benke and also Dr. Maureen Kinje and I will be speaking on the Friday session. So I hope to see many of you there, and I'll be sharing slides then. But just to share some thoughts as well. So touching on what all the other speakers have spoken about, we do see that there's a relatively strong body of evidence on the biological impacts of HIV, as well as antiretroviral therapy exposure on children and their long-term outcomes. But what is lesser known are the socio-behavioral family exposures. And we find that general non-HIV specific risk factors for poor neurodevelopment, we do find they are amplified among families affected by HIV. So Dr. Wamalwa touched on some of these, but food insecurity and poor nutrition, growth faltering, preterm birth, intimate partner violence, or potentially household violence in general, lower education, or potentially socioeconomic status factors may be impacting child neurodevelopment, and these are magnified among families affected by HIV. So we want to pay special attention to these children. And as many of the speakers said, and especially Dr. Collette mentioned, that this is going to require multifactorial solutions and interventions that target very specific areas. And there are many areas to target. So how do we know where to go next? And so that's part of what we're hoping to do in some of our studies that are ongoing in Kenya. So one study in particular, the HOPE study, which many of us on the panel are working on, is a longitudinal cohort of children who are HIV exposed, uninfected, and children who are HIV unexposed, uninfected, and their mothers. And we've found that mothers of children who are HIV exposed, uninfected, had lower education, higher food insecurity, less stable partnerships, so more likely to separate in the first 2 years of the child's life, more likely to be in polygamous marriages, and to have less financially supportive male partners. We found that poor neurodevelopment scores were associated regardless of if the child was HIV exposed we saw that some important factors were if the parents had been together for a shorter duration of time, if the father was living separately, if the father was not financially supportive, or if the father saw the child infrequently, so low frequency of interactions between father and child. These are all significantly associated with poorer scores. And so some of the work that we've been trying to understand is around the nurturing care framework. And the nurturing care framework, if you're not familiar with it, was developed by the World Health Organization and UNICEF and has selected 5 domains. These 5 domains, if they are adequately provided, they are there's evidence that a child has the best chance of thriving. So these are physical and mental health as one, adequate nutrition, opportunities for early learning, safety and security, and responsive caregiving. And the nurturing care framework is something that we're really trying to understand in our among our families in Kenya, and to conduct qualitative and mixed methods research to understand how caregivers, both mothers and fathers, understand the nurturing care framework. And where do we see the biggest challenges? Because that might be a great starting point for interventions. And really trying to understand the father perspective more so than what we've looked at in the past. We find that oftentimes, as many of us know in pediatric HIV research, we work very closely with mother and child. But the father perspective has often been lost to us. And that is an area where our team is really interested in understanding better. And just understanding what the roles of fathers and male partners is. It's just been much less understood in the context of HIV. So to understand this and to address this gap, we are conducting qualitative research with fathers. We are even adding in photo voice research with fathers, whereby we give a camera to fathers to really help us visually narrate their stories and elevate their voices in this conversation for children. We are also doing some work to understand the bonding activities. So Dr. Brent Collette and I are really fascinated by oral storytelling. What are the stories that parents tell their children? Do mothers and fathers tell different stories? And how might oral storytelling impact language development among children? And then lastly, we're hoping to leverage evidence-based interventions for fathers and couples and adapt them to meet the unique needs of families affected by HIV. So there's a wealth of knowledge around interventions that improve child neurodevelopment outcomes, and we think that they are ripe for the picking. So they are ripe for adaptation to support families affected by HIV. And so now is the time to act. We look forward to collaborating together. Thank you.
Thank you so much to our panelists and our presenters. I think we'll open it up for the presenters to respond to the questions. They've been responding to them on the chat box, but I think it might be worth asking Prof. Omalwa and Prof. Benki to maybe respond to some of the key questions that have been raised in the chat box. Start with you, Prof. Omalwa.
Thank you very much. Yes, indeed, there were many, many questions that touch on different things, and I'd like to respond to some of them. So the question about the role of other opportunistic infections, such as cryptococcal meningitis, toxoplasma, and TB meningitis. Yeah, these are important causes of both neurological and even neurocognitive decline. And in many of the studies, this would have been excluded. They would not. The comparison would be between children who didn't have these conditions. We know that they confound, and in fact, at the end of the talk, when I talked about what's proposed as a newer classification, one of the challenges is just how to separate that. So that question is relevant in that if there's TB meningitis and cryptococcal meningitis or toxo, those should be identified and treated. But despite that, there'd still be the evidence is that there are still some deficits that would be there even when you don't have those conditions. So that's one question. There's several questions on the regimens. Specifically the CNS penetration. I'd like to point out, and Grace made that point very well, that we have inability to measure what's going on. And remember, she said the three spaces. There's plasma, there's the CSF, and there's the brain. And the CSF is close to the brain, but it's not the brain. And so clearly this is a challenge. We cannot keep looking in people's brains to see whether there's virus there. We cannot even keep looking in the CSF practically, but we have the plasma that we can measure. And the selection of the regimens, even the guideline review and trials, a lot of time have gone through comparisons and seeing what's effective in controlling plasma viral load. So in a way, that's the best we have. So the regimens that have been chosen are effective. They do have some toxicities, but I would say we would not use this framework to say that now we have to change ART. Remember, for the more serious forms of CNS disease, this recovery, like I pointed out, children recovered, and the most important thing is still to get virus suppression that we can measure, and that's in the plasma. So it may be a different thing if you have a child who's deteriorating, and then you could case by case interrogate and say, what can you do? But we wouldn't use this position to say that now we recommend change of regimens. The regimens have been chosen based on trials that show that this is effective and tolerable and reasonably safe. There's questions about other sort of slightly, there was one specifically about Clickstone in terms of treatment. And yes, I think the thing about cryptococcal meningitis, not the commonest in children, the physicians who are here will most likely have seen more of it. But when we do see it, then what's known is that you don't want to start treatment so quickly because of the risk of iris, immune inflammatory syndrome. So that is not. There's a question on whether there's someone say so long-term suppression and still neurocognitive impairment. Yes, that is true. So it's just that there are other factors that can cause impairment, and Grace did point out again from the CROI studies about that. Irene, let me stop there. Maybe Sarah can respond to some of the others, and also the other panelists. I can see Sarah, you may want to talk about mental health or something.
Yeah, thank you so much, Prof. It seems like one common theme in at least some of the questions is this idea of, how is it possible that, in the setting of long-term viral suppression, you still have neurocognitive impairment. And I would just add that, we are really interested in trying to understand what might be happening in the CSF. That is a really challenging compartment to collect and look at carefully, systematically, just because it's a very invasive type of sample. But that would be incredibly helpful if we could. And it's very intriguing that, we have tried to look over time at, how markers in the bloodstream, such as RNA, and how, very rare populations of the long-lived cells that are involved in the HIV reservoir are related to the cognitive outcomes in these cohorts. And, although in general, some markers that you would expect would be related to poor cognition, such as, higher RNA or higher numbers of cells, there are still some mixed results. And so I think what that means is that we haven't quite landed on exactly the best way to look at these different markers, but it's certainly a really important aspect of the work to try to understand what might be the difference between these children who have perhaps an ongoing inflammatory process in the brain that's causing an active or like some sort of a decline versus ones that are affected by these legacy by something that happened a long time ago in early life. I want to just also ask Dr. Collette a question. You mentioned trying to understand how we could support language and motor functioning as a way to support executive functioning. And I'm just wondering if maybe you could also comment on it seems like one other way to get it, because I really you know, as important it is to try to understand how we support early learning and early childhood development. What's hard is that a lot of children are now adolescents and school age, and so what do we do to best support them? And so I'm just wondering if we might start to talk about ways that we can support executive functioning during school age and during adolescence, perhaps by you know, emphasizing certain activities that might support planning, attention, and self-regulation.
Yeah, good question, Sarah. And I was realizing as I was saying that I wasn't being super clear. This is kind of a new thought that I have in mind. So it's not super well formulated. And I will say that most of my expertise is with young kids, so I'm not quite as familiar with all of the evidence for older kids. But one interesting example, so there's a preschool curriculum called the Tools of the Mind that has been studied. And that intervention was a bit of a response to, in the US, this tendency to sort of overvalue academic skills and pre-academic skills. So instead of doing a whole lot of drilling in like reading activities or that kind of a thing, for example, in classrooms that use this Tools of the Mind intervention, there's a much heavier emphasis on play and pretend play and things like this that are a little bit more naturally occurring. The way that they work in some more explicit intervention around things like planning and things like that is that they have kids think about their day. So the kids will come in, and at the beginning of the day, the kids will sort of think about the things that they want to play. So the centers where they really want to play that day. And they'll work with a teacher or an assistant in the classroom, and they'll kind of map out what their day is going to be. And the examples of this are adorable, as you might imagine. But basically, kids kind of think ahead, and they say, "Well, I want to play with the blocks, and I want to play dress up, and I want to play with, you know, my friend on the playground." And so then the teacher would help them write that down, and they would say, "Okay, so you want to be sure to do all of these different things during your day." And then they would sort of scaffold that for them and try to make opportunities available so that they would be able to kind of execute that little plan that they had. I think there are other examples like that, where essentially it's just a little bit of a scaffold, a little bit of a support that would sort of nudge a child or an adolescent in the direction of developing a plan ahead of time and then executing that. You could easily think about how that would work for adolescents, for example, like if they've got a bunch of different studies that a bunch of different classes that they need to study for, you know, they could get some support thinking about a plan for that. So you've got this amount of time to study. How are you going to spend that time? And I guess what I'm suggesting is that in general, that kind of a thing that's sort of more tied to other areas of development that are naturally occurring, activities that are naturally occurring, is likely to have more benefit than anything very specific to those executive function tasks. Where there, sorry, Irene, I see your comment, but that's the gist. I think it's probably going to be something like that, that's starting with the developmental domain, things that kids are involved in day to day, and then building on that instead of something specific to executive function.
Thank you so much. And thank you so much for the presenters and the panelists. As you can see, the schedule for the week is up. So please join us as we continue talking about mental health, talking about HIV exposed and infected children. That was one of the questions that came up in the chat box throughout the rest of the week. So I'll hand it over to Agnes.
Thank you, Irene. Thank you for all our presenters, for our panelists. Thanks for taking the time to share with us these great insights and the studies. And thank you for our attendees for staying with us till the end. You're welcome for the remaining sessions during the week. Yeah, do have a great night or great day from wherever you are. Thank you so much all. Goodbye.
Bye-bye. Thank you.